You go in for 2 days, chest pain. The doctors check you out, run some tests, send you home. Then the bill arrives. It's 40 pages long. Every hospital in the US maintains an internal price list called the chargemaster, with up to 50,000 individual line items, one for every service, one for every drug, one for every item they hand you, touch, or roll past you in the hallway. The chargemaster amount is almost never what a patient actually pays. That sentence is on the hospital's own website. So the price isn't real, but it's on the bill. And if you don't have insurance, it's the price they send to collections. Here's how a number that nobody pays became the number that broke 100 million.
About 100 million Americans, 41% of adults, carry healthcare debt. That's not people who can't afford rent. That's almost half of U.S. adults, including a lot of people who have insurance and thought they were covered. Altogether, Americans owe at least $220 billion in medical debt, according to KFF analysis of federal government data. By the end of this video, you'll understand exactly where that debt comes from. Not a guess, the actual mechanism. It starts with a price list that, by design, nobody is supposed to pay, and ends with the one group of people who actually do. There is no law telling hospitals how to set chargemaster prices. No formula, no required relationship between what something costs and what they charge. A hospital can charge whatever it decides to charge. So how do they decide? Mostly, they don't. Health policy researchers describe chargemaster prices as the rough equivalent of a car's manufacturer's suggested retail price, the price a seller would ideally like to charge. Except on a car, the MSRP has some relationship to what the car costs to build. On a hospital bill, that relationship is optional. The number on the bill is not a cost. It's not a calculation. It's an opening bid based on whoever runs billing that year, based on what they've always charged, adjusted upward, and never once reviewed by a patient before it arrives. That's the what. Here's the why. The chargemaster was created in 1965 when Medicare launched. Hospitals needed a standardized way to report charges to the federal government, so they built a list. Every service, every item, one number each. The government paid off that list. It was an accounting tool, nothing sinister, a spreadsheet. Then, private insurers arrived and changed the math. In the 1980s and 1990s, private insurers started demanding discounts off the chargemaster prices. Give us 30% off. Give us 40%. Fine, but the hospital still needs to hit its margin. So if the insurer wants a 40% discount, the hospital starts with a price high enough that 60% of it is still profitable. This upward spiral has continued for decades. The same peer-reviewed study puts a number on it. Each additional unit of chargemaster markup correlates with $261 more in profit per inpatient discharge. Not because the uninsured paid it directly, because the inflated baseline changes what everyone negotiates around. The list no one pays is still making money, just indirectly. The result: insurers typically negotiate the chargemaster price down to a contracted rate. The patient then pays a share of the contracted rate, their deductible, their copay, and the rest is covered. A hospital might list a service at $1,000. The insurer's contracted rate is $700. Your 20% cost share is $140. Medicare and Medicaid skip the chargemaster entirely. The federal government pays hospitals according to its own fixed fee schedules. The chargemaster is irrelevant to what Medicare pays. It doesn't exist for that transaction. So for most patients, the chargemaster price is theater. The real price is negotiated in private before you ever get sick, between your insurer and the hospital. You don't see it. You're not in the room. In 2013, a journalist named Stephen Brill spent 7 months reading real patient bills. The story ran 24,000 words in Time magazine. People called in sick to read it. One bill, from a cancer center in Houston, listed a charge of $7 for a single alcohol prep pad, a small square of cotton they use to wipe your skin before an injection. $7 for cotton. The same investigation found a drug billed at $13,702. The hospital had paid $400 for it. Also on the bill, $32 for the rental of a reusable blanket. These weren't errors. This was the chargemaster doing its job. The items were entered correctly. The prices were exactly what the list said they should be. That was the point Brill was making. The list itself was the problem.
A peer-reviewed health affairs study from Johns Hopkins published in 2016 found that the charge-to-cost ratio across hospital departments ranged from 1.8 for routine inpatient care all the way to 28.5 for CT scans, 28.5 times cost. For every dollar a CT scan cost the hospital, the chargemaster said to bill $28.50. Anesthesiology was right behind, at 23.5 times cost. And here's where the steel man goes. Because the people who built this system weren't mustache twirling. When insurers started demanding discounts in the 1980s, hospitals had two choices: say no, or inflate the list price so the discounted rate was still profitable. They picked the second one. Every stakeholder was making a rational decision. Nobody had to write down a formula, so nobody did. Nobody had to justify the price to anyone, so nobody did. The result is a system that no one would rationally design from scratch, which is fine because no one did.
Between 1996 and 2017, chargemaster markups, the gap between what hospitals listed and what things actually cost, grew by an average of 155% across more than 3,400 hospitals over 21 years. Not a blip, not one bad actor. A steady climb, industry-wide, for 2 decades. And the variation across hospitals, how differently they were inflating, grew by 324% over the same period. The list got higher, and it got more chaotic. Here's the part that actually matters. The people who get billed closest to the full chargemaster price are the uninsured, the people with no insurer in the room to negotiate on their behalf. No contract, no discount. No one making phone calls for them. Just the list. That's not an accident. The chargemaster exists to give insurers something to discount. There's no mechanism for an uninsured person to do the same thing. They're a customer in a car dealership where every other buyer has a fleet negotiator, and they walked in off the street. Non-profit hospitals, the ones that claim tax-exempt status under federal law, are required to maintain a financial assistance policy. That's the safety net. But there's no federal income threshold. Each hospital sets its own, and patients have to know to apply.
So the safety net exists. It's just not automatic, not uniform, and not the thing anyone hands you when you're trying to leave the hospital and read a document you've never seen before. And then there's this. In 2021, the federal government required hospitals to publicly post their prices. As of late 2024, only 21.1% of hospitals reviewed were fully compliant, according to an independent watchdog that audited 2,000 hospitals nationwide, a drop from 34.5% earlier that same year. The law that was supposed to make prices visible has been largely ignored. The prices are still there, just not for you.
One of the line items billing advocates find on hospital bills is listed as mucus recovery system, $8. It's a tissue box. Non-sterile gloves, the ones they snap on to examine you, appear at $53 a pair, adding up to over $5,000 in gloves during an average hospital stay, according to billing advocacy data. These numbers are funny, and they're also the whole argument. The chargemaster is a list of numbers that doesn't have to mean anything. No formula required. No relationship to cost required. It started as a bookkeeping tool in 1965 and became, over the next 50 years, the architecture of a system where prices are set in private, negotiated in private, and revealed only after the fact on a bill that most people have no idea how to read. Billing advocacy researchers estimate that somewhere between 49 and 80% of hospital bills contain at least one error: duplicate charges, services never rendered, items billed at the wrong code. Any patient has the right to request an itemized bill, a line-by-line breakdown, with every charge, code, date, and price. Federal rules require hospitals to provide one. That right exists. Use it. Medical problems contribute to 2/3 of U.S. personal bankruptcies, according to a 2019 peer-reviewed study. Contribute to, not cause alone, but still, 2/3. The chargemaster is a fantasy. The debt it creates is real. The tissue box is $8. At least they named it something good. If you've ever wondered how concert tickets went from a reasonable annoyance to a $400 insult, the next video has the full breakdown. Hidden fees, fake scarcity, middlemen who appear from nowhere to take 30%. Same energy, different industry. It's the same list, just with a different name on it.